Chapter 13, Decision Support. So measurement provides decision support and drives innovation. Three main purposes of measurement in population health are improvement, accountability, and research. Decisions in the areas of improvement, accountability, and research require different types of decision support. So on the last slide, I mentioned that there were three main purposes for measurement in population health, and they were improvement, accountability, and research. So this slide I'm going to talk a little bit more detail about each. So for improvement, it's measured just enough to learn. Also, they have limited data and small sequential samples. And then also hypotheses are flexible. And trend data are typically analyzed. Now for accountability, focuses on reporting, oversight, comparison, choice, reassurance, or motivation for change. There's no hypothesis testing, evaluation for performance, and also importance to make adjustments to reduce bias. And then in the research, it seeks to discover new knowledge that may have broad application where standard of evidence is beyond doubt. Also, the tests are carefully blinded and controlled. It seeks to eliminate bias, and the hypotheses are fixed, traditional statistical techniques. So this slide just gives you a little bit more information on improvement, accountability, and research. It kind of compares them, shows what the aim is about, shows what their methods are that are used. If they talk about bias, sample size, and then the confidentiality of the data. So like I said, this slide, just review it. You don't have to memorize it, of course, but it does give you pretty good information as far as the differences of the three purposes of measurement. So the model for improvement was built on a rich tradition of quality improvement measurement methods dating back to the early 1900s. So part one, let's talk about the three questions. So the first part here focuses on these three basic questions. What are we trying to accomplish? So in other words, here we're talking about we need a clear goal statement, make them SMART, or in other words, specific, measurable, attainable, realistic, and time-bound. And then also, how do we know that a change is an improvement? Here, tools of statistical process control were developed to answer this question. Process involves plotting data over time and applying tests to determine whether there has been a change in the underlying results of a process. First step, gather data on performance. Data then plotted on a run or control chart. Trend graph, trend graph that includes a medial line, then predominantly display them for review. So now a control chart is actually a more sophisticated version of a run chart and is used to detect special cause variation, and also it adds upper and lower limits. And then the final question is, what change can we make that will result in an improvement? So and actually, part two actually helps to answer this question. The rapid and continuous cycles of the Plan, Do, Study, Act. So here, it consists of a continual cycle of Plan, Do, Study, Act to test and implement changes in real-world setting. So for Plan, we're going to be developing objectives, predictions, and plans to carry out the cycle. For Do, we're going to be carrying out the plan and documenting data and observations. For Study, we're going to analyze the data, comparing results to predictions and summarizing what was learned. And then the Act, determining the changes to be made in the next cycle, after which the cycle repeats. So a key feature of the model of improvement is the rapid and repeated use of the PDSA cycle, or the Plan, Do, Study, Act cycle. So the predictive modeling, it's actually another set of powerful tools for performance improvement. This predictive modeling relies on mathematical algorithms to predict the probability of an outcome. So this is usually done within population health. Predictive modeling is typically used to predict such outcomes as cost, resource utilization, or mortality by population segments. So the ultimate goal of predictive modeling is delivered tailor interventions and resources to a specific population segment based on their specific need. Also, two key predictive modeling questions. What are you predicting? Why are you predicting it? How accurate is your prediction? And then what actions are taken based on the prediction? And then also the quality of predictive models, the sensitivity and specificity. Sensitivity, which is a true positive rate. It measures the percentage of high-risk individuals who are currently identified by the model. And then specificity, which is a true negative rate. It measures the percentage of individuals not at high risk who are currently identified by the model. So actually sensitivity and specificity are competing objectives. Okay, so let's go over sensitivity and specificity in a little bit more detail. So in this study here, you have 15,480 members in this study. Of this, 774 ended up having the given condition. So that means that of the 774 that had the given condition, only 158 actually were diagnosed correctly. So this is where the study said, yep, these people are at high risk and have the condition. So they're saying that 158, which is the actual number of participants that had the condition, divided by the total number of participants that were earmarked that ended up having the given condition. So you would divide that and then multiply by 100. So they're saying the sensitivity of this model was 20.4%. So on the flip side, so we said that there were a total of 15,480 people that were members. Of this, 14,090 were correctly predicted to not have the condition. So of the 14,090 divided by the total number that were predicted not to have the condition multiplied by 100 gives you the specificity of 95.8%. So then this study also is telling you that there are 616 false positives and 616 false negatives that were in this study. Now, a perfect model would have a sensitivity and specificity equal to 100%, but in reality, there are no perfect models. Measurement for accountability. So we're measuring the triple aim, and for the triple aim, our goal is to obviously improve population health. So models by Evans and Stoddard, which is in 1990, expanded the relationship between healthcare and disease by describing broader determinants of health, including genetics, physical and social environment, and behavior. This also broadened the concept of health beyond the absence of disease to include well-being and prosperity. So following Evans and Stoddard model, Kingdig and Stoddard later added important dimensions of distribution of health in a population to differentiate it from individual health. So the conclusion of analysis, healthcare's relatively small contribution to population health when compared to the contribution of behavioral, environmental, and genetic determinants. So we want to also in the triple aim improve the care experience. So an article that was in the periodical of Crossing the Quality Chasm stated that this was a landmark report, and the care that is safe, effective, patient-centered, timely, equitable, and efficient. Here it's useful as a framework for measuring the determinants of the care experience and providing decision support for those managing the health status of populations. And then also too, we want to also improve the per capita cost. Here the concept of cost measurement is more straightforward because there are common monetary units with built-in exchange rates that easily can be rolled up or drilled down. Now, this is complicated because number one, it requires a population denominator for measurement, which makes it difficult to identify the population served by the delivery system, and also it's unclear which costs to include and from whose perspective. Now, we also have three lenses on cost, and now that's the different lenses assist in understanding the cost being measured. You have a supply lens on the providers, or a supply lens of the providers. You have a demand lens of the consumers, purchasers, and general public, and then also you have an intermediary lens of health plans and insurers. And then also too, under measurement of accountability, we have measuring value and efficiency for value, efficiency, and return of investments. And we're actually going to discuss these on the next slide. So under value, it's worth, utility, or importance in comparison with something else. So it requires a determination of what would be given up in exchange for something, indicated by the amount of money a person is willing to pay for something. Ultimate test of value is choice. Key characteristics of value is that it is subjective, there is no right answer, Different stakeholders have different perspectives on value. And now for efficiency, or in this case, efficiency of care. So measure of the relationship of the cost of care associated with a specific level of performance measure with respect to the other 5 IOM aims of quality. And then the last one here is return of investment. So this describes the size of return relative to an investment. For any 2 projects, the one with the lower return of investment may actually have the higher total savings. Very important to purchasers evaluating disease management programs. So for an example, if program 1 costs $1 million and returning $3 million in savings, it has an ROI of 3 to 1 and $2 million in savings. However, program 2 costs $10 million and returning value of $20 million in savings has a 2 to 1 ratio for the ROI and a $10 million in savings. So the one with the lower ROI produces $8 million more in savings. So Population Health Alliance recommends net savings over the return of investments in the evaluation of disease management programs. Measurement for research. The efficacy research. So you have whether or not an intervention can work under ideal conditions. Now these would be for clinical trials or examples of efficacy research. They are designed to isolate the effect of a particular intervention by controlling for other factors of potential influence. And then effectiveness research, whether an intervention works in routine clinical care. Also, we've got comparative effectiveness, which compares healthcare interventions to determine which is the most effective or provides the best chance of positive health outcomes. Then you have cost effectiveness. So the cost effectiveness research is mainly the cost of a program or intervention associated with a given level of effectiveness. And then the quality adjusted life years is a year of life lived in less than perfect health compared to a year of life in perfect health. Measure of individual health most commonly used in cost effectiveness analysis. So in conclusion, decision support tools and methods used in population health depend on the kinds of decisions needing support, such as improvement, accountability, and research. It is important to consider how they fit together in an integrated analytic and evaluation system. An example, the Triple Aim framework. While used here to illustrate accountability measurements, it is also useful for improvement. So that concludes Chapter 13. And again, if you have any questions, please let me know. Thank you.